So I'm going to spend about 20 minutes talking about chemotherapy in bladder cancer. And what I thought I would do is use 3 case studies to review the role of chemotherapy in 3 different settings. One in the metastatic setting, that is when the cancer has spread beyond the bladder and we aren't able to completely surgically remove it. And then in the neoadjuvant setting and the adjuvant setting. These are when we give chemotherapy around surgery, and Dr. Drachenberg talked about that a little bit, and I will talk a little bit more about that. There's one other area where we will give chemotherapy, and that's in patients that are getting radiation. I'm actually not going to talk about that because Dr. Ong is going to spend some time talking about that. So just to review, and Dr. Drachenberg started to, or talked about this, if we look at the genital urinary anatomy, we are born with 2 kidneys. The kidneys produce urine. Urine is a way of the body to flush toxins out of the system. The urine flows through 2 tubes called the ureters, where it's stored in the bladder until we urinate it out. And because the urine, which can be filled with toxins, is stored in the bladder for a period of time, the bladder is at risk for being damaged because of these toxins. So if we look at the risk of bladder cancer in patients in Canada, in Manitoba in 2012, it's going to work out to be about 280 new cases of bladder cancer. And if you look at men and women combined, it's the 5th most common cause of cancer. And unfortunately, in 2012, about 70 patients are going to lose their life due to bladder cancer. And if you look at men and women combined, it's the 8th most common cause of cancer death. So the first case is a 70-year-old male who presents with a history of intermittent hematuria, meaning that there's blood in the urine. Workup identifies bladder cancer. A CT scan shows that the cancer has spread to the non-regional abdominal lymph nodes. These are lymph nodes that are present outside the immediate vicinity of the bladder and can't be completely removed with surgery. He has no cancer-related symptoms. So what is the best treatment option for this patient? Now, before I talk about the treatment option, let me just talk a little bit about how chemotherapy can work in bladder cancer. And I'll go through this diagram. So this is a cancer cell, a bladder cancer cell. The bladder cancer will produce individual DNA proteins. These individual DNA proteins can come together and form DNA strands. The DNA in the body or in a cell is primarily responsible for holding all the genetic material that allows the cell to grow and divide. So it's essential for the cell to function. So the cell will duplicate this DNA within the nucleus of a cancer cell. And when the DNA is duplicated, it can cause different things. It can produce proteins that make the cell grow or do different functions within the cell. And it can also duplicate it in complete fashion and allow the cell to divide and form other cells. Now, our chemotherapy can inhibit this process in a number of ways. One way that it can inhibit the ability for a cell to grow is to inhibit the production of these individual DNA proteins. That's one way that chemotherapy in bladder cancer works. Another way that chemotherapy can work in bladder cancer is that it can actually form cross strands or binding of the DNA together. So it actually forms essentially a large clump of knots, if you will. And when there's this clump of knots, the DNA isn't allowed to be duplicated or replicated. And when it can't duplicate or replicate, it can't grow, the cell can't grow and can't divide, and therefore it'll die. Because cancer cells are more active than normal cells, chemotherapy preferentially targets cancer cells rather than normal cells. So in 2000, there was a landmark clinical trial that was published that looked at an older chemotherapy regimen that had been used traditionally with a newer chemotherapy regimen. The older chemotherapy regimen was called MVAC. It had 4 chemotherapy drugs in it, and it was fairly toxic. And it compared it to a new clinical or a new chemotherapy group called GC, or gemcitabine and cisplatin. This was a randomized controlled trial. A randomized controlled trial is the best way for us to decide if one group of drugs is better or worse than another. So this clinical trial evaluated 405 patients. They all had newly diagnosed metastatic bladder cancer, and they were treated with up to 6 cycles of chemotherapy. Half got the old treatment, the MVAC, and half got the new treatment, the gemcitabine and cisplatin. All these patients had minimal cancer-related symptoms, and all of them had underlying good kidney function. Now, I'm going to tell you about the results of this clinical trial. And before I go through the details of it, I have to just say that these are numbers. These are statistics. And so an individual person sitting in my office when I talk with them about that may not exactly fit within these categories. So you have to take all these numbers with a little bit of grain of salt. But what they found in this clinical trial was that those patients that got the GC chemotherapy did just as well statistically as those that got the more traditional 4-drug combination chemotherapy called MVAC. So about 50% of the patients would have a significant shrinkage in their tumor. And about 12% of patients would actually have the tumor completely shrink away to nothing, so you couldn't see it at all. If you look at the whole group of patients, the median overall survival in that group, that's the time when half the patients remain alive, was 14 months in the gemcitabine cisplatin group. Again, when we say median survival, half the patients are alive longer than those numbers, half the patients are alive less than those numbers, and they are just numbers. But that's what the clinical trial showed. So it showed that the gemcitabine cisplatin was just as good in controlling the cancer as the more traditional 4-drug combination. This trial was updated in 2006, and what they found was that there was a group of patients that had advanced cancer from the from the bladder, who actually ended up doing quite well. So if you look 5 years down the road, there's about 15% of patients who are alive and doing okay. So some patients, even with advanced bladder cancer, can do well. There are some side effects with chemotherapy. These side effects include things like nausea, vomiting, diarrhea, low blood counts, infection, rash, hair loss, sore mouth, kidney damage, and some numbness and tingling in the fingers and toes. What they found with this clinical trial was that patients that got the gemcitabine and cisplatin had significantly less serious side effects than the group that got the older, more traditional chemotherapy. They also found that the group that got gemcitabine and cisplatin had an overall improvement in their quality of life compared to the group that got the MVAC. So this clinical trial essentially changed how we treat patients with advanced bladder cancer. We now use gemcitabine and cisplatin because it's just as beneficial in terms of controlling the cancer. It's associated with less side effects and improved quality of life. Now, not all patients with advanced bladder cancer will do the same. Some patients will end up doing better and some patients will end up doing worse. And so the question is there any way for us to determine which patients might do better and which patients might do worse? This is from a study that was presented at a major scientific meeting earlier this year. They looked at 400 patients that were treated with chemotherapy, and they identified 3 risk factors that suggested patients might do worse with their advanced cancer. And these 3 risk factors included an increase in the white blood cell count above 10, those that had evidence of cancer in the lung, liver, or bone, and those that had at least some cancer-related symptoms or a lot of cancer-related symptoms. And so patients could get 1 point for each one of these 3 variables, and depending on how many points a patient had, you could sort of get a sense of how they might do. So, for instance, if a patient didn't have any of those 3 risk factors, you look at the median survival in that group, the time that half the patients remained alive. It was about 27 months. Again, that's just a number. Half will do better than that number in that group and half will do worse. If you had 1 risk factor, the median survival was 17 months. If you had 2, it was 13 months. And if you had all 3 of the risk factors, the median survival, the time that half the patients would remain alive, would be around 10 months. So these are things that we use to talk with our patients and give them a sense of how aggressive their tumor might be and give them a sense of what they're up against. But again, some patients will do very well with their treatment. If you look on the internet or look through the literature, there's a few other things that I think we should touch on. One is that there was a recent study that tried to add a 3rd drug to our GC combination called paclitaxel. This was recently published. And what they found was that the 3-drug combination actually wasn't any better in terms of outcome or survival than the group that got the gemcitabine and cisplatin chemotherapy, but was associated with more toxicity. So this is a regimen that's not commonly used. If patients have underlying kidney dysfunction or significant hearing dysfunction or some significant numbness and tingling in their hands and feet, we will oftentimes substitute the cisplatin with another drug called carboplatin. So we'll use gemcitabine and carboplatin in this group. And these patients can also do well, and it's been shown that this drug combination can be effective in patients with advanced bladder cancer. So, getting back to our scenario, the patient completed 6 cycles of gemcitabine and cisplatin chemotherapy. His cancer didn't go away completely, but did stabilize, and he did well for quite a while. 18 months later, his cancer begins to grow again. He now has some mild cancer-related symptoms. And so the question is, are there any other treatments that could be available for him that could help him? So in individuals where they've been off of chemotherapy for more than 6 months, we will oftentimes consider a retrial of the same drug that we use, the gemcitabine and the cisplatin. If that drug combination isn't effective, or has lost its effectiveness, or the cancer has grown within a 6-month period, we will oftentimes think about switching to a different type of chemotherapy drug. And I've listed some of the common chemotherapies that have been studied in this second-line setting. As you can see, if you look at these studies, most of them will show some tumor shrinkage, usually in the range of between 10% and 50%. This is a significant tumor shrinkage. Now, all of these studies are relatively small, usually with 30 to 100 and some patients. All of the studies did not compare one drug with another drug or one drug without any drug. So because of that, we can't say for sure that second-line chemotherapy makes people live longer. One would think it probably does if it's controlling the cancer and shrinking the cancer, but we can't say for sure that that is indeed the case. And because the combination or these drugs have not been compared one to the other, no one can say for sure which is the best chemotherapy drug to use in this situation. So there's no standard second-line treatment. So we'll oftentimes talk with our patients about using one of these agents in the second-line setting when gemcitabine and cisplatin has lost its effectiveness, provided that they are up for it and that they aren't having too many symptoms from their cancer. Now, there are ongoing clinical trials that are evaluating a number of different types of chemotherapy drugs, both in the first-line setting where the cancer is spread and also in the second-line setting. Most of these drugs are looking at targeting specific pathways that are involved within the cancer. And hopefully within the coming years, we're going to have better treatments that are more effective in controlling advanced bladder cancer. Okay, so the second case is a 65-year-old male who presents with recently diagnosed urothelial carcinoma of the bladder. CT scans show a tumor that extends completely through the bladder wall, but not into adjacent structures. There's no evidence of any lymph node involvement or metastatic involvement. No evidence that the cancer has spread beyond the bladder. His kidney function is normal. What are his treatment options? And this leads to the question about, can chemotherapy play a role around surgery? We know that surgery is the biggest player in localized cancer. It's the only way, generally speaking, of getting rid of it completely. But does chemotherapy have some benefit? And Dr. Drakenberg talked on this, and I'll talk a little bit more about it. Usually chemotherapy in this setting is given to try and improve the chance that the cancer won't come back after surgery. If we give chemotherapy before surgery, we call it neoadjuvant chemotherapy. And if we give it chemotherapy after surgery, we call it adjuvant chemotherapy. There are a few potential advantages of giving neoadjuvant chemotherapy. One is that it can shrink the cancer down. If you can shrink the cancer down, it may make surgery, complete surgical resection of the tumor, easier. The other advantage of it is that you can target tiny cancer cells that may have begun to spread right away as soon as it's diagnosed, without having to wait for the cancer cells that spread to grow. So that might also be beneficial. Generally speaking, when we are thinking about perioperative chemotherapy, chemotherapy around surgery, we use the same chemotherapy agents that we've talked about in the metastatic setting. In Canada, most of the time it's gemcitabine and cisplatin. The side effects of chemotherapy in this population or in this setting are generally the same as what we've talked about in the metastatic setting. And we generally think about this approach in patients who are having few cancer-related symptoms, we call good functional status, have underlying good kidney function, and don't have any significant comorbidities that might give us problems with treatment, such as significant hearing loss, numbness and tingling in the hands and feet, or significant heart problems. So there's been a number of studies that have looked at chemotherapy before surgery. Some of them have been positive, some of them have been negative. And so what has been done is investigators have looked at combining all the clinical trials together into one study. It's called a meta-analysis. So they did a meta-analysis of these 11 clinical trials that included just over 3,000 patients. And just as Dr. Drachenberg mentioned, patients that got neoadjuvant chemotherapy had an improved 5-year overall survival rate than those that didn't get chemotherapy. So their chance of being alive 5 years after their cancer was higher in the group that got neoadjuvant chemotherapy than the group that didn't. For the group that didn't, it was around 50%, and for the group that did get chemo, it was around 56.5%. So that absolute difference was about 5 to 6.5%. So one way of looking at that is if you would treat 100 patients with chemotherapy before surgery, an extra 6 of them wouldn't have the cancer come back that otherwise would have. Now, it's just a number, and it doesn't say the whole story. If you look at the clinical trials, between 25 and 40% of patients that got chemotherapy would have the cancer completely go away at the time of surgery. So they couldn't find any cancer at the time of surgery. Those patients still need surgery, but if you look at how they do 5 years down the road, their chance of being alive is much higher. It's around 85%. So those patients that have an excellent response to chemotherapy have a better chance of beating their tumor. So because of this, neoadjuvant chemotherapy is considered the standard approach for patients that have bladder cancer that's requiring surgery. With the caveat, though, that it needs to be patients that are healthy enough to receive it and don't have conditions that might preclude us from using the chemotherapy. The third case is a 55-year-old female who presents after undergoing bladder cancer surgery. Pathology shows a tumor that extends through the bladder wall. One abdominal lymph node had cancer in it that was removed. All visible cancer has been removed at the time of surgery, and CT scans show no evidence of any metastatic disease. Her kidney function is normal. So the question is, are there any treatment options for her now to decrease her chance of the cancer coming back? And just like in the neoadjuvant setting, there have been a number of studies that have looked at giving chemotherapy after surgery to decrease the chance of the cancer coming back. Some of those studies have been positive, some of them have been negative. So a meta-analysis was done looking at all these studies together. There were 6 studies in this population, just under 500 patients. And what they found was that adjuvant chemotherapy might be associated with an improved outcome. They couldn't say for sure that it was, they thought it might be. The benefit did not meet statistical significance in terms of it wasn't statistically robust. But there looked like there was a trend towards improvement with adjuvant chemotherapy, and that trend translated into about an extra 10% improvement in 3-year survival. So a way of looking at it is if you treated patients, 100 patients with treatment with chemotherapy after surgery, an extra 10 of them wouldn't have their cancer come back that otherwise would have. Now, there's been some studies that have come out recently that suggest that the benefit of chemotherapy, it's not proven, but there might be a benefit. It's probably going to be in those patients that are at highest risk of having their cancer come back. And we think those patients that are highest risk are those that have involvement of the tumor that extends through the bladder wall. As Dr. Drachenberg mentioned, those are T3s or T4 tumors. Or in those patients that have involvement of regional lymph nodes that are present with cancer around the tumor. There's also some evidence that maybe giving chemotherapy sooner rather than later, if you're going to give it after surgery, might be beneficial, i.e. less than 8 weeks after treatment or after surgery. This is still an area of controversy, and it's an area that if you are in that situation, you should talk it over with your healthcare providers to see if chemotherapy would be a benefit for you or not. If patients receive neoadjuvant chemotherapy, then generally speaking, no matter what, we generally don't give chemotherapy after surgery. Now, just like in the metastatic setting, there are ongoing clinical trials that are looking at different types of chemotherapy in the neoadjuvant and adjuvant setting, and hopefully in the coming years we'll have more treatments that have increased benefit. So with that, I'm going to stop, and I'm going to conclude by saying chemotherapy plays an important role in the treatment of bladder cancer. It has proven benefit in patients where the cancer is spread beyond the bladder and can't be removed with surgery. Some of those patients will do very well with treatment. It has proven benefit in the neoadjuvant setting. It's considered standard treatment. And it may have benefit in the adjuvant setting in selected individuals. That's a little bit more controversial. There's many new treatments that are being looked at right now in clinical trials, and hopefully this will lead to improved outcomes in the coming years. So with that, I'm going to end, and thank you.